will discuss the anesthesia protocols for the awake spine surgery and what recently it can be modified to cope up the surgery. With the time, spine surgery has been evolved a lot for doing an open spine surgery to microscopic and to the recently it has been as a keyhole surgery. So as the anesthesia technique has to be modified. Let's learn by an example. So there is a female 76-year-old with a severe back pain, radiculopathy. She has a severe stenosis, L3445. She is obese, diabetic, hypertensive, chronic kidney disease, and her heart condition is compromised with an ejection fraction of 25% and with anterior hyperkinesia. Interlaminar endoscopy at 2 level has to be done. So what can be the anesthesia plan? Let's take it one by one. The main concern for the general anesthesia is patient is already compromised cardiac function. So intraoperative hemodynamic instability or cardiac failure can occur. Postoperative delirium, cognitive dysfunction. Patient has already CKD, so postoperative renal dysfunction or the multi-organ failure can happen. The major disadvantage for the spinal anesthesia would be it has a limited duration of time. We cannot give a top-up dose. And moreover, after the dural puncture, the ping-pong feeling of the dura is not well appreciated. Moreover, spinal anesthesia is definitely motor blockage bound to be happen. Post-operatively, urinary retention and post-operative mobilization is delayed. The best would be the local anesthesia. Yes, that's the advantage of preserving the motor function. So intraoperative neuromonitoring we can do. But sometimes it has unsatisfactory effect and patient will have continuous feeling of some instrumentation over the area, surgical site. And again, there will be, sometimes there may be a pain by retraction of the nerve and it can cause the severe pain and patient can go into the vasovagal shock. So our desire anesthesia, what should be ideal anesthesia? It should include all the advantages of local anesthesia, that patient is awake, and it should exclude the disadvantages of general and spinal anesthesia. So I have proposed doing a segmental sensory epidural anesthesia in which patient is totally awake, responsive, there is no motor blockage like this local anesthesia, and it has no side effects systemic like general or epidural anesthesia. In the normal routine epidural anesthesia, we do it in the sitting position or in the lateral position, and it is a Bryan procedure. In contrast to the conventional technique, what we do in SSC is we do it in the prone position and strictly under the IITV. The catheter in needle should insert one level above. This is L3-4 level, this is 4-5 level, this is the surgical site. We need to insert the needle one level above and from the contralateral side. So the surgical field is totally cleared. This is a needle inserted, and from the needle we insert the catheter and we inject a dye. Dye is most important thing in our anesthesia. Injection of the dye, it confirms the placement of the catheter in the epidural space so that we learn that there will be short effect of the anesthesia. And secondly, after the injecting of the dye, we see the extension and the spread of the drug, so that it tells about the requirement of the volume of the drug we want to inject. Again, the monitor is attached and the sensory block is given, and effect is checked after 20 to 15-20 minutes. If required, we give midazolam or fentanyl as a sedation. Positioning is must. Abdomen should be free. Proper bolster, proper padding should be done. Patient is given slightly head position to decrease the epidural congestion and the neck pain due to the education. This is an intraoperative video of interlaminar endoscopy with the same patient. Endoscopy is being performed. You can see the patient is totally awake, responsive, and with the rock-steady vitals. This is the post-operative, immediate post-operative, where you can see patient is able to move his limbs and patient is responsive totally. This is the catheter side and this is the surgical incision side. So there is a huge distance between them. Post-operatively, we monitor patient. We keep the NBM for 30 minutes. We can emulate the patient immediately. So because it is only sensory block, there is no need to immobilize the patient. And we can discharge the patient on the same day. The same way we can do thoracic endoscopy under the SSE. Is a patient with D1110 PID at you can see the patient is awake. Catheter is inserted in the D10 space. From the left side, endoscopy is being performed. This is the post-operative, immediate post-operative phase, where you can see patient is responsive. Patient can lift his leg. We have been doing MIS TLIF as well in the SSE. You can see the catheter. MIS being performed. And patient is totally awake. This is the post-operative catheter in situ. One peculiar thing about the SSE is that it differentiates between the retraction and the stretching. This is a case of severe L5 S1 stenosis, where there is a huge disc, and patient, we cannot get beyond the roots. We cannot get the lateral to the roots. After the burying, the patient was having a pain, severe pain. And if when we go lateral to the nerve, we find out that there was a conjoint root. That is why the patient was having a pain. So in whether it's a general anesthesia or any other anesthesia, the conjoint root or maybe missed or injury can happen. So the most important benefit is intraoperative neuromonitoring. Patient can able to move his or her legs. The total motor blockage is not done. We can get patient's feedback intraoperatively, whether pain is relieved or symptom has been relieved or heaviness or tingling has been relieved or not. Intraoperatively, we can make the patient to cough to raise the intra-abdominal pressure so that any loose fragments or we can define the completion of the surgery. Again, it can differentiate between the nerve retraction and the nerve stretching. Normal retraction of the nerve will not cause the pain. But if you stretch the nerve too much or if you retract the nerve too much, it causes the pain. So nerve injury can be avoided. We can mobilize the patient immediately. Other benefits are avoid for GA and the decrease in cardiorespiratory function, post-op morbidity, mortality, lowers the pain score, positioning, injury can be avoided. Most importantly, it can be done in the high-risk patient and patient can be discharged on the same day. We have been doing the SSE in all the high-risk patient, cardiorespiratory dysfunction patient, multi-level pathology can be addressed in revision spine surgery or previous fixation, we can do. These are my results. We have doing more than 350 cases under the SSE, including the transforaminal, interlaminar, UBE, MIS cases, endovascular infusion. Thank you. Thank you.